The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Why Wait for the Crisis out-of-home care for seniors. This is obviously a program focused on out-of-home care, living arrangements, and health care for seniors who need it. So our two presenters here we have today, we have Caitlin St. George, who is a community liaison from the Yeti Visiting Nurse Association. And we also have Deborah Hanish-Schreyer, who is a geriatric care manager. So I believe Caitlin's going to start us off with the first topic, which is why wait for the crisis.
One, I want to thank you guys for coming, especially after work, during the work week. You can't avoid every crisis that is out there, but the more information that you have, you're going to be better prepared. And the time to start planning is not when you or a loved one is laid up in a hospital. Because unfortunately, a lot of those options are going to be taken away from you. Whether availability of beds, financial options of services, location. I'm a big believer you don't know what you don't know, and we probably get bombarded with information all the time about services that are out there. But until you really need it, how much do you internalize it? And I've been with the Eddy 14 years. 8 of my years was in our housing division, which is our retirement assisted living communities, dementia-specific living communities. Past 6 years, I've been with our home care agency, and also 2 of those years, I was helping marketing our nursing homes. And I got to tell you, the calls we get are the calls of people in crisis. And those are really the unfortunate ones. And I do a lot of presentations. I see a total of 4 people that I saw this past weekend at a conference that I was at, gathering information. And a lot of times when I go out there, especially if I'm talking in a senior center, I'm in a housing building, most people that are older don't think that they need our services. When I was with assisted living, I had assisted living behind me. No one would want to make eye contact with me because, oh, I don't need it. Maybe later I might need it. I don't need it right now. And I understand that. And I look at my parents. I lost my dad this past fall, 89. My mom is 86. And it was really hard seeing them go through the process and starting to need more services. And I am the youngest of 5 girls. And being the youngest, they don't think that I really know much about much. That even though I've been in this field for so long, they looked at me as their baby. And so when I would talk with them, it was based out of care and concern. Have you thought about this? Have you thought about a home care agency? Thought about adult day services? Really didn't really internalize it. And my sisters and I were all talking with each other. And we finally talked to my parents and said, would you rather us talk to you or about you? And they didn't like the idea that we were talking about them. So they understood we can talk with them about things. They may not agree with it. Cognitively, they are completely capable of making their own decisions, but they don't know services that are out there. And so gathering your information, you may not need it now. You may not need it next week. You may not need it next year. But what I like to think of, services that are offered really are to help keep you more independent. For those of you that attended our last session, we talked about services going into the home. It could be visiting nurses, it could be a companion aid, help like housekeeping, meal preparation, medical transportation, maybe connecting somebody with adult day services, maybe one of those mobile health alerts to, I've fallen and I can't get up. That if something happened, you have access to the help that you need. I understand it's hard. I look at my parents, and I think it was probably pretty frightening for them. They were losing their friends. They've already lost their parents. Some are losing spouses, they are losing siblings, losing ability to drive, losing ability, my father, to go up and down stairs. He was a college professor, still very, very much aware, and I look at how frightening it was for him to have to go through that, how vulnerable he must have felt. And talking about giving him supports really was to help him. It wasn't to take away his independence, is we wanted to keep him as independent as possible. So when you have conversations with your loved ones, be mindful of that. And also, if someone's having a conversation with you, try to be open to that as out of care and concern. I have a friend who's a carpenter, and he said he's able to apply those skills in everyday life, is that he's learned to look at something at every angle. And so I encourage you, with your loved ones, to look at things at every angle. It's a really tough spot to be. Now, you were recently in the hospital? Yes? No?
No, my aunt was.
Your aunt was, that's right, okay.
Yeah.
So, if anyone has been in the hospital recently, length of stay is getting shorter and shorter and shorter. Gone are the days when you're in the hospital for a month. When women are having babies, they're usually out within what? Less than 24 hours? It's pretty frightening. And if you look at the shortening of length of stay, the minute someone enters the hospital, hi Joe.
Oh, how you doing?
They are planning your discharge. They're planning it, connecting you with services, seeing what's out there and seeing what supports you have. And so those days are getting shorter and shorter and shorter. And so when you're ready to leave that hospital, whether you're going home to a nursing home or assisted living, you're going to meet with a discharge planner. And that's going to talk about the hospital stay. But whether you're 18 or 88, and those discharge instructions are coming at you fast and furious, new medications, new diagnosis, how do I take my medication, signs and symptoms, when do I go to the ER, when do I call my doctor? If you were like my father, he would have guessed that discharge planner. Yes, I get it, I understand it, yes, I understand it. And then when they landed in their home, he really didn't remember much. And again, I don't care if you're 18 or 88, when you're in that acute setting, you really can't comprehend everything that's coming at you, and it's coming at you fast and furious. And so services coming into the home can help. Also, I'm going to talk about assisted living, doing your homework beforehand. So if you ever get to the point of you are unfortunately in a crisis because you can't avoid all of them, you have an idea of what's out there and where you would like to go or your loved one would like to go. Be mindful of time. I'm going to turn it to Deb. Okay.
The most important thing to realize about being in the hospital is that it is an acute care setting. And so you go in when you have an acute need, and as soon as you have stabilized, not gotten all better, but stabilized, it's time to move on. I often, as a geriatric care manager, and I'm a social worker, I have been working in a private practice for the last 14 years. What I find is that is very often the time that I get the call, because mom has just had a stroke, or something has happened. They wound up in the hospital, and as Caitlin said, almost immediately staff are thinking about stabilization and then moving on. And for family and friends and what have you, they're saying fix my loved one and don't send him home until he's all fixed. And it doesn't work that way. I have found that it's critical to have an advocate with you, as you had for your aunt. When you're in the hospital, you're ill, you're acutely ill, something is going on, and you can't advocate for yourself. You can't pay attention, you can't take notes. I mean, people are coming in and out. I mean, if you don't have a loved one to really be with you as much as possible, to make sure that they can talk to the doctor, it's really unfortunate. When my father-in-law was in the hospital, and he was 95, his wife, my mother-in-law, spent a lot of time during the day with him, but she went home. I was back and forth. My husband, the other sons, and a lot of family members would come in and out. And often my father-in-law would say, and he was cognitively intact, but he was, woozy and ill and what have you. And when we would come, he'd say, the doctor was in here talking to me. I don't know what he said. So of course, that's going to be a tough one. So do try to have, someone else that can ask the questions and stay on top of things, because that discharge comes really, really quickly. The hospital, the discharge planner, as the name indicates, is the person that is responsible for making the arrangements to get you out. But you do need to realize that they've got a huge caseload. Their job is to get you out of the hospital, and though the goal is a safe discharge, it doesn't always happen because there are so many details involved in a safe discharge, and they don't have the time really to wrap things up neatly in a bow. But that is for advocates, for your family members, or if you are the one in the hospital, that's important information to know. So you want to make sure that you're stable enough and functional enough to go home. For instance, if you live alone and you can't get in and out of a bed or a chair by yourself, that's not a safe discharge. A plan needs to be made, and that's where home care or family can come in to help. But that is the goal. But the problem is everything is so rushed, as Caitlin said. The stays are so brief, and for instance, if you go in with an infection, an acute infection, they will give you an IV antibiotic. And from there, when you can then step down to an oral antibiotic, you're ready to leave. So it's not like you're in there for 10 days until all the treatment is done. You're in there enough to get stable enough to leave. So that's an important one, important piece of information. One thing that used to be a huge problem that has been resolved but still needs attention is the whole issue of observation status versus admission to the hospital. It's perfectly understandable that when you come in through the emergency room, which is the normal entrance, and then you get sent to another room, on a floor, you think you're admitted to the hospital. And you may be having tests, and you may not be admitted. You may not be officially admitted. Now, this caused problems specifically when people wanted to then go to subacute rehab in a nursing home. And the criteria for that is that you have 3 overnight stays in the hospital to be officially. You have to be admitted. You have to be in admitted status. You have to have 3 overnight stays. Then when you go to the nursing home for subacute rehab, Medicare and insurance will cover it. And there was just so much confusion. Fortunately, this has been resolved, and a law has gone into effect now, in which you must be notified within 36 hours of being in the hospital as to what your status is. Now, the good news is, well, and let me finish that thought. So with that, you will get a notice. It's called a MOON, Medicare Outpatient Observation Notice. So if you are on observation status, within 36 hours, you will get that notification. So you know that. Observation status is covered, the tests that you may be undergoing, the time, the tests that you're undergoing are covered by insurance, Part B insurance. Admission to the hospital is Part A, talking Medicare. So there is a difference. And you will find out the difference in, when you get your bill. But the critical piece about understanding where you are vis-a-vis the goal of getting into subacute rehab, that has been resolved pretty much. But do be aware that this is something you want to be notified of. And my experience has been that the hospitals are doing this. They're doing it. Now, my experience also is that in the hospital, they're coming in and out, they're telling you this and that, they're saying sign this and that. So you might not really understand what that is, but hopefully, this is what the issue is. There is also an appeal. Come on in.
We just wanted to find the picture.
There is an independent peer review organization called Levanta, which covers all, which is a review process to look at all Medicare covered services with regards to an appeal. So if you are in a hospital as Medicare covered, or it pertains to subacute rehab in a nursing home as well, which is Medicare covered. If you are unhappy with a decision that's made and you've attempted to talk it through and you cannot resolve it to your satisfaction, a Levanta appeal is always a possibility. Now, in the hospital environment, I'll give you an example of where this does come up frequently. You're in the hospital and they're saying, okay, it's time to be discharged. And you don't feel, for any number of reasons, you were supposed to get a GI consult, you were supposed to get this test, there were things that were discussed or things that are outstanding that have not been done, and now you're being told you need to go. You will say, I'm not ready to go. What about the GI consult? Or what about this or that? If the hospital staff don't feel that that's appropriate, if they feel from their position, from their side, you have an acute need, it's been resolved, it's time to go. They will tell you it's time to go, and you'll say, but what about this? They will give you a notice saying it's time to go, and Medicare will not be covering your hospital stay anymore. At the bottom of that notice, you can appeal that, and so this is where a Levanta appeal comes into play, and you basically have 48 hours, 2 days, in which the records are reviewed by an independent organization of physicians who review what has happened, whether it's appropriate, whether everything was done as it should have been, and appropriately. At the end of, and during that time, you can stay in the hospital. Okay, so that threat, if you will, of having to pay privately because you won't be covered does not pertain during that review period. You will get an answer at the end, and at that point, when you get your answer, and Levanta says, we agree that it's time for discharge. From that point on, if you refuse to leave, then you are on the hook for paying privately. And people don't do that because they have had the experience of having another medical opinion, essentially. So keep that in mind. And there is a number for Levanta if you want to take it down. 866-815-5440. You can Google it and it'll pop right up. So there's that. I guess, in summary, as far as the hospitalizations, they're quick, it's coming at you fast and furious. Do have an advocate. It's very, very helpful. And so one of the things that happens post-hospital, when you're ready for a discharge from the hospital, it may be that you live alone. It may be that that home care, if you live alone and you need some help, home care is always the first call. It may be, however, that you need a more comprehensive environment. And so an assisted living may be a choice for you, and Caitlin's going to talk about that. And you'll cover, there are particular eligibility requirements for that, so take it away.
Right. I did pick up, and I encourage all of you to take one. It's put out by the Guardian Society. It's a housing options book. It's wonderful. It covers independent living. It covers the several forms of assisted living as well as nursing homes. It breaks down the criteria as well as some of the financial eligibilities. It's a great book. I'm going to talk about assisted living. Are people familiar with that term? Okay. And assisted living is kind of a generic term. There are other different types of licensures. New York being New York has really made it complicated. There's adult home, there's assisted living residence, there are enhanced assisted living residence, there's enriched housing, and there's enhanced special needs. Those all fall under the assisted living category. So it's really, really complicated. This kind of breaks it down in there as well. With assisted living, I've been in home care for 6 years, and so I really work on providing services to keep people in the home. And that's where people want to stay. But if people cannot stay there safely, there are other options that are out there. And again, it's something that people tend to dig their heels in. And what I find is that once people get into a community, they wish they did it years earlier. They really, really do. And if you look at even just the whole socialization piece is humongous. And if people are experiencing losses, a loss of a loved one, a loss of a sibling, a loss of a spouse, if they're in that supportive environment of an assisted living community, they tend to fare better opposed to if they were living in their home. The socialization piece is humongous. I always encourage people, make the move sooner than later, because people put it off, they put it off, and they put it off, and there's specific criteria to get into an assisted living community. And a lot of times, people put it off so much that they now exceed the criteria, and they have to go to a nursing home because they can't go into the assisted living community. So I always encourage people to make the move sooner than later, as well as there's a community that you love. You think, you know what, I'm really going to be happy there when I'm ready, not now. And when I'm ready, then that's where I'm going to go. But if something happens, you end up in the hospital, and they're saying you cannot safely return to your home, and you want to go to that community over in Guilderland, there may not be an apartment that's open. And that's the sad piece, is that a lot of times it is based on availability. So you may end up, because they can't discharge you to your home because it's not safe, you may end up in a community that you necessarily didn't want to go to in the first place. So I always encourage, make a move sooner than later. Now with the different licensures, and again, it's going to break it down in here because we could spend an entire day on the different types of licensures that are out there. But with adult home, enriched housing, assisted living residence, the criteria for admission is people need to be able to ambulate 150 feet independently. If they're in a wheelchair and they can self-propel, if they are in a walker and they can go 150 feet, then that's considered appropriate. They also need to be able to get in and out of their chair on their own. Assisted living communities, the adult home, enriched housing, assisted living residents aren't allowed to do transfers. They can do it once in a while, but if it becomes something that's a regular occurrence, then they're going to be looking at transferring you to the next level of care. Assisted living communities are great. Most have private apartments. There are some communities that are out there that you can share an apartment with somebody. They vary from a studio to a 1-bedroom to a 2-bedroom. You have your own living space. Usually there's going to be like a microwave, a coffee maker. I think some of the older communities might still have the ranges. And if someone has a cognitive ability to use a stove, they can use their stove, but most don't have those. So you can prepare things in your apartment. You make it your home. You bring your own furniture, you decorate it, you've got your pictures, your family photos. This is your home. But again, part of the goal of assisted living is you're not going to spend the entire time in your apartment. So some people say they go and they look at the communities and look, oh my gosh, this is so small. I could never possibly live in this space. I look at myself, and I live in a little bungalow, it's just myself and a dog, but how many rooms in my house do I really use? I really don't use a lot. I use my living room, I use the bathroom, my bedroom, the kitchen when I cook, which isn't that often. But most people don't really realize they might be in this huge house, but really only using a fraction of the space. So the goal is you have your own time in your apartment, and then there's lots of activities that happen on the campus. There could be bingo, there's outings, there's arts and crafts, there's entertainment. There's also going to be common areas where you can sit, watch TV, watch movies, and get to know the other residents that are there. It's a very wonderful, supportive environment. In the communities, there are 3 meals that are provided a day. You're going to have lunch, breakfast, and dinner. Some communities, they may allow you to take your breakfast in your apartment. But regulatory communities at the assisted living level, people do have to go down to have the meal. And that's part of your interacting, you're getting that social interaction. So regulatory, you can't take all your meals in your apartment. Obviously, if someone doesn't feel good, they're going to deliver a tray to you, but they want you out and meeting people on the campus. Some communities have assigned seating. Some people let people sit wherever they choose, but people tend to find people that they like to sit with, and that's where they tend to go during every meal. Meals are different at every place. Sometimes there is going to be a menu that you get to choose from daily, or sometimes there's only going to be a couple of options. And again, if you look at the financial range of communities that are out there, there are going to be some that are really high-end. Then there are going to be some that are Medicaid community as well as subsidized. So obviously, if you're looking at something that's more high-end, it's going to have a little bit more of the bells and whistles than the other communities do. A couple things that I tend to talk about with people when they're starting to look at assisted living communities. If you're looking for a loved one, check out a bunch in the area and narrow it down to ones that you think your loved one might like. Everyone's idea of home is completely different. So if I was looking for a campus for my mother, I might find something, I get in there, I love it, I love the decorations, I love the feel, I love the energy, and it may be something my mother may not like. She might get in there and maybe not her what she's looking for. So narrow it down to a few communities and then take your loved one and let them decide what ones they want. And here, again, it breaks down different options. A couple of things to ask when you go. A big one is, what would be a reason my loved one couldn't live here anymore? Or what would be a reason I could not live here anymore? And again, going through the criteria is regulated by New York State with the 5-6 different levels of communities. They all have different criteria. In the adult home, enriched housing, and assisted living residence, the admission and the discharge criteria is the same. If someone's been living in the community for a while and they can no longer ambulate independently, 150 feet, you can get PT to come in, you can do strengthening to see if you can get back to baseline. But if it gets to the point they can't do that, then they're looking at transitioning to a higher level of care, a nursing home. The other type of assisted living communities, enhanced assisted living residents, special needs assisted living, they're different. They work with the state and determine what the admission and the discharge criteria is going to be. And if you go back to that old criteria, getting in and out of your chair on your own, transferring independently. If you think about it, if the only thing someone can't do is get out of a chair on their own, do they really belong in a nursing home? I don't think so. So that's why there are the different levels of assisted living. And so it's important to ask, what is their licensure? Again, what would be a reason my mother would need to leave? Or what would be a reason I need to leave? And those enhanced assisted living residents, they work with the state to determine the criteria. Enhanced assisted living residents could almost do everything that a nursing home could do. You could do tube feeds, you could do vents. If they determine with the state that's what they want to do. But not every enhanced assisted living resident is going to do that, because the idea of assisted living is to be, again, more social. It's not a nursing home. So I understand wanting to keep people living at that level longer, but at some point would your assisted living end up looking like a nursing home? So there's a very, very fine balance. And it's important to ask those questions. Licensure, what would be the reason my mother couldn't live there? And again, New York State is very confusing with adding different levels of licensure in there. Another thing to look at, again, when you ask what would be a reason my mother couldn't live there, a lot of places have the policy, can't pay, can't stay. They don't tell you that up front. If you run out of money, you get that 30 days notice and you're expected to vacate your apartment, which usually you end up going to a nursing home. Some communities that are out there, they ask for a financial application up front. I know the Eddy does. I don't know what other communities do. They look at someone's age, they look at income, pension, Social Security, all of that. I know what we do is we look at someone's ability, usually to private pay, about 2 years. But again, we would look at a frail 86-year-old very, very differently than a 70 spry person. So that frail 60-year-old, we're going to probably looking for less money, thinking they're not going to be able to stay with us probably more than a year and a half. So we're not going to look as much as finance. But that 70-year-old, he's staying with us a decade. So they're going to look at probably more in the financial range when it comes to them. What I can say with us, and again, I don't know what other assisted living communities do, if we approve someone's application and we said this is going to be your home, if they don't self-impoverish and give all their money away, if they were forthright and honest around their application and they spent down all of their money and they can't pay anymore, we're going to renegotiate their rate. It could be an SSI rate, it could be down to a Medicaid rate. If we've said it's your home, it's your home. And not all communities do that. And it was at the Tools for Caregivers conference this past Saturday, and a woman's in another assisted living community with a month's left of private pay. And she's in a panic. I did talk with her about some options, but that might work for her based on where she is. But ask that question. What happens if I can't pay? What would be reasons why I can't stay? Those are important things to look at. I also encourage people, when you're touring with someone who is a sales staff, their goal is to sell you that apartment. That is what they're doing. You want to ask that person, how long have you been with this company? How long has the director been in this company? Talk to the personal aides, because they're the ones who are doing the hands-on stuff. Find out how long the aides have been there. I know communities that aides have been there decades, and they're not there decades because they're making a lot of money. They're there because they care and they're doing a good job, and they're working in an environment that's good. I once worked for a community. It was well before the Eddy. It had to have been 15 years ago. And talking with and I was a salesperson. When people were coming to tour with me, I'm showing them the community, introducing them to people, hoping they're going to pick the community that I'm in. I heard another person who was in my position, and it made sense that they lost a family because there was a dead plant. And the family said, if you can't take care of that plant, how can I know you're going to take care of my mother? And you know, that makes sense. So when you're looking at communities, how clean is it? Does it smell? What's the landscaping like? Are people sitting in the living room slumped in a chair with stuff on them? Those are things to look at. go at odd hours. So you can see what's the evening staff like. What's it like on a Sunday morning? Not when all the staff are there. Do not be afraid to ask questions. It's a really big responsibility moving someone to an assisted living community. Ask to speak with other family members to see if they are happy. Every assisted living community has what's called an ombudsman. Are people familiar with that term? Okay, an ombudsman is a person who, I don't know who they're assigned to the state, I believe, into an assisted living community and a nursing home, who is neutral. So if someone is fearing that, oh, if I go and talk to the director about I'm not happy with care of my mom, are they going to retaliate and I'm not going to know what's going on, you can go and talk with the ombudsman in confidence, and no names are ever discussed. It's just issues, and if it can be resolved, if not, then it goes into investigation or back to the health department. You can also go online in the health department and find out really what the status of their surveys have been. In a survey, they do at assisted living, as well as in nursing homes, where the Department of Health goes in and there's certain criteria and things that have to happen. And so you can see what communities are out there that aren't doing so good. I can say in the Capital District, for the most part, we have good assisted living communities. I mean, if you look at like downstate, like New York City, Jersey area, there's some real nightmares that are happening. But look for their survey. They should be displaying their survey. If they're not, ask them to see that. It's a big responsibility. But if you do your homework now, you can see what's out there. It may not be the financial option that's out there for you. There are very few communities that do accept Medicaid. I'm trying to think. It used to be Hearthstone Village in Troy. Now it's called, pardon me?
Elves.
Yeah, ELPS, assisted living programs. They are the ones that accept Medicaid. So we had the former Hearthstone Village, is it the Pines in
Right.
Troy? They do accept Medicaid. Delmar Place, which is an Atria community, I believe about 20 of their beds, they are called low-income beds, but they will take people that I believe are on the Medicaid level. I can tell you there's a waiting list right now. There's a community in Troy, I'm not going to tell you the name. Unfortunately, some folks have to go there because they have no other place to go. If you walk in and it's not clean, you don't get a good vibe, you have a very young crowd, and it's the only option you have, I encourage you have a very strong presence for your loved one. As well as any of the communities that you go to, make sure that they know who you are, having a strong presence, question anything that you feel you're not comfortable with. And again, unfortunately, there are not a lot of good options out there for the lower income. It's unfortunate. And it's a huge need in the Capital District. I'm going to move on to the special needs assisted living communities. Yes?
Can you just go back with the assisted living? Do most of them charge a different rate being what people need?
It depends, and that's a great question. There are two types of ways fees are paid. Some, there's a monthly fee. It doesn't matter how much care you get, how little you get. It's your room, your care, your meals, your activities. And then there are some that are tiered. So your mom's only getting meals, activities, her apartment, and assistance with her medications. Might be a lower tier, but then now mom's going up to the next level. They're assisting her with bathing, dressing, grooming. Next level, they're putting her on a toileting schedule because she has incontinence that can be managed. There's two schools of thought when it comes to that. With the tiered level, you're not paying for a service that you're not getting. And so some people say, oh, mom doesn't need that, so I don't need to pay for that. But then with the flat level fee, you don't need to worry that you're going to get nickeled and dimed every month when she starts to need more care or you start to need more care. So there's benefits to both. I see benefits to both. Services that assisted living provide, again, like assistance with medications, you've got your meals. They can assist with bathing, dressing, grooming. If they need that, they can also do queuing. Maybe if someone just needs someone to help them to do their hair, to get dressed, all the way to fully helping someone get dressed. With the enhanced special needs, those are assisted living communities that are secure. and they're geared specifically for people that have dementia. It could be Alzheimer's, it could be frontal lobe. Those type of communities really are geared specifically for that population, and they are locked. And I believe it's 7 out of 10 people with Alzheimer's at some point will wander. A lot of people say, well, mom hasn't done that yet. It never has to get to the yet. So if you look at the enhanced assisted living, it really is an environment that is conducive to a person with dementia. There's not going to be overhead paging, which could be pretty freaky for somebody if they're thinking they're hearing things coming from the ceilings. Staff are trained how to approach a resident. If it is 5 o'clock and someone's starting to become agitated, it's called sundowning. It's not necessarily when the sun comes down, but it's internally when things are supposed to happen. You're getting out of work. The children are coming home. My partner's coming home. I've got to prepare a meal. So internally something's happening. So a lot of times in the dementia-specific community, right around that time when someone might be starting to get agitated, we engage them in an activity. It could be folding laundry, sorting socks, setting the table. Maybe they want to help sweep the floor before dinner, but it's in getting them engaged in an activity. They also don't reality orient to anybody. And someone could say the sky is a lovely shade of green, and it's a pretty shade of pink. But I would say, yes, it is a lovely shade of green. You don't reality orient somebody because it's a no-win situation. And when people progress with their different types of dementia and Alzheimer's, it's their short-term memory that's going first. And so initially, the memories that they established are going, and they may be back to when they're in elementary school in their mind. So it's really, there's a term called therapeutic fibbing. People say, I could never lie to my loved one. It's not lying, it's helping keeping that person calm. There's no need to get engaged in a battle. No one's going to win if you're engaging in something that's not that person's reality. So communities are geared specifically for that population. Activities are very simple that they can follow. With the dementia-specific communities, they're not going to be sitting with a menu in front of them because that just might be too much for them to make those type of choices. So there's going to be very, very limited. Let's see. Things that would differentiate traditional assisted living to dementia-specific assisted living. Both are going to do an assessment to see what's the best environment for your loved one. Someone could be regular assisted living and have Alzheimer's or different forms of dementia, but you're going to look at one, safety has to be top priority. Are they at wander risk? Are they in danger of themselves, or are they in dangers of others? Another thing that we're going to look at is dignity. The dignity of that resident. Are they going to go to the front desk in the regular assisted living community 50 times a day asking for lunch because they're insisting we haven't fed them, because they don't remember that they just had dinner? Looking at, are they now withdrawing from activities because they just can't follow them anymore, they're staying in their room? So when it comes to traditional assisted living or dementia specific, we're going to look at safety as well as we're going to look at personal dignity of that resident. People can stay at assisted living and pass away there. We have people that are on hospice. The state's gotten a little better. In the past, they used to say if someone was going on hospice and they were in assisted living, they were to be transitioned to a nursing home, which I think is cruel. This person has lived in this community. Hopefully they should be able to die in that community. So the state now is looking away, as long as those needs can be met, keeping them in their environment, opposed to they now have hospice, uprooting them and sending them to a nursing home. Most times people, when they do leave the assisted living community, except that enhanced one, which I was talking about, because they can keep people there longer, and it's all broken down in here, most people will transition to a nursing home. The staff at the assisted living community are going to work with you. It shouldn't be sprung on you that mom's got to go in 30 days. They should be communicating early on with you if they feel that it's going to be necessary to make the next step and work with you on transitioning her to another home. Questions? I covered a lot. I am going to encourage you that I want you to take this because it is a wealth of information. I also did bring, we talked, the last presentation we did on adult day services. It's a great guide. It talks about where programs are, contact numbers. And I did also bring some of the Eddie's information. I talked too long. So turn it over to Deb.
Okay. When assisted living is no longer enough, and that is a transition point, that is often the time when I get a call for assistance as a geriatric care manager, or when someone is in the hospital and they are seeking subacute rehab. That's another point of request for assistance. So, Caitlin did a great job of talking about the different levels and the ability of the assisted living to address greater needs. But there is definitely a point in time where a nursing home is necessary. Not everyone gets to that point in time, as Caitlin said. You can die, you can come to the end of your life in an assisted living if that's, what happens. But there often comes a point where that transition is necessary. So the definition of a nursing home, it's, that's such an antiquated term, but it's still used, all the time. But it is, they used to call them residential health care facilities, which they are, and they still are. Now that became indicative of a lower level of care. We don't need to talk about that. It relates to PRI scoring. It is now really commonly called a skilled nursing facility. And both of those terms are very helpful and appropriate because in the first term, it is your residence and it is a healthcare facility. So, and in the second term, it is a skilled nursing facility, and you will receive skilled nursing care, typically, and more, and then some. So, and I'm going to fall back on nursing home because that's the colloquial term. A nursing home provides room and board and comprehensive health care services. So the basic services are oversight of your medical care. There is a physician and typically a nurse practitioner helper that are responsible for overseeing medical care. Then there are nurses, registered nurses, LPNs that are responsible for overseeing the aid care, the administration of medications, and coordinating things. Because in a nursing home, you're not really seeing the doctor you see the doctor once a month or as needed. I mean, you can be seeing them very frequently if you're undergoing changes. But the nursing care is a critical component. So they are communicating with the doctor if there is a change, if they think that something is happening that needs to be looked at, if there is a medication issue, medications need to be changed. There is that constant communication. Although from the resident standpoint and the family, they often feel like, we never saw a doctor. But you are, they're there, and they're overseeing care. There are social work services. You'll see a social worker when you're coming in. You'll see all of the disciplines when you're coming in, whether you're coming in for rehab or you're coming in for a short stay or a long stay. You're going to get an evaluation from all of the disciplines. And the social worker is a critical piece of the picture, and if there are difficulties that are adjustment or mental health, psychiatric, that's when or family issues, that's when the social worker will really come to the fore. There is physical therapy, occupational therapy, speech therapy, available to all residents in a nursing home as needed. Those are the key services when you're coming in for subacute rehab. I'll talk a little bit more about subacute. Similar really to the way Caitlin described assisted living. It is, it's a comprehensive environment with services, activities, meals, religious services, visiting pets. I was just in a nursing home and they had a pot-bellied pig visiting. And that was really fun. And they just walked the pig around to all the different residents and then they would do tricks. So, there is a stated goal in the regulations that when you go to a nursing home, you shouldn't be isolated from the community. They really want the resident to be integrated, to be integrated into the community, which is very hard to do. But the way that it is really done is to bring in activities and bring in people from the community that can enrich your environment, essentially. In addition to, there's also this medication management. There's a pharmacy that oversees, that uses your insurance and will supply the medications that the nurses are going to give you. Mobile imaging, so if you need an x-ray, it's a nice feature that comes into assisted living as well. You don't have to go out for an x-ray. The idea when you're in a nursing home, ideally, is to get all of your care in the nursing home, because very often you're at a point where going in and out is difficult. But that does happen. There are folks that go into a nursing home and are very committed to, seeing their cardiologist or their GI doc. The doctor in the nursing home is your primary care physician. So when you go out to see specialists, that their recommendations come back and are reviewed by the house doc, who then really has the ability to overrule if he or she doesn't feel that it's an appropriate recommendation. But typically, there is good communication. And ultimately, hospice is, if you're in a nursing home long term, there will come a point, and that is when hospice comes in, when hospice as a program is available to come in and provide. It's really oversight. It's kind of a consulting service in terms of the hospice nurse, whose specialty is pain management, comes in and consults with the staff of the nursing home. So it's very much a collaborative effort. And hospice also has volunteers that can, and social work services in addition, and chaplain service in addition. So if you are in a nursing home on hospice, you're getting, an enriched and enhanced, essentially, level of service. Let's see, I want to make the point now, and I want to make it, I want to make sure that I make it clear. I really feel that nursing homes have gotten a bad rap. In my position, I have clients in nursing homes. I visit them frequently. Nursing homes are surveyed by the Department of Health. The standards of care are rigorous. If they are not being met, there is ongoing monitoring. There can be sanctions and fines and what have you. So nursing homes are well supervised and well overseen and a very appropriate place to be if you need it. Coming into a nursing home, as I said, you're coming in 3 different ways. If you're coming in for subacute rehab, the expectation is that you're going to get your rehab. It's going to be covered by Medicare, and for the first 20 days, then days 21 to 100, if you continue to need that, is covered. There's Medicare pays 80, and your co-insurance hopefully pays the balance. Depends on your insurances. That's a whole other story. But typically, the co-insurances are picking up or paying 150, 160 in that day 21 to 100. When you're coming in for subacute rehab, you need to demonstrate that you are improving in order to continue to get reimbursement from Medicare and the co-insurance. And so how that happens is that the therapists are documenting, 150 feet this week, next week 175, working on this, working on that. It is clearly documented, and then the nursing home gets approval for a little more rehab. So it's well monitored. Sometimes, so when you're in the hospital and that's where you're going, and the expectation is you're a good candidate and you're going to come out the other end. What happens is the hospital therapist, PT, as well as the doctor, will determine that that's an appropriate next step for you. The facility, the nursing home, will look at the recommendation from the doctor, from the physical therapist, occupational therapist, speech therapist, and very often that's enough to say, okay, come on, we're going to offer you better. In some instances, and I see this quite a bit, in some instances where it doesn't look like it's a slam dunk that you're coming out the other end. It looks like, well, you're in a rehab might not do it all. You might wind up needing a continued stay in the nursing home. They ask for an application, a universal application it's called, which is really a financial document. They're thinking, okay, after rehab is over, if you are unable to leave, which means you can't go home with home care safely, assisted living is not the appropriate setting for you, there isn't family that can fill in the gaps, it might be that you're going to stay there. That's when they're going to look for the financial picture, see whether you can, what you've got. And the reason for that is that once you are in a nursing home, you cannot be discharged for lack of ability to pay. Unlike assisted living, which Caitlin was saying, that does happen in a good number, actually, not the Eddies, but a good number. In a nursing home, you go in, here's a scenario that can happen frequently. You go in for rehab is over, you really can't leave. You stay there, you spend down all the money that you have, and then you would convert to Medicaid. And Medicaid would pay the balance of your stay. So, so there is that assurance. What I am seeing is that, there are a good number of nursing homes that just ask for the application along with information from the hospital, just to kind of hedge their bets. And that's not unreasonable. If you're going into a nursing home, so that's rehab. And then you might go into a nursing home paying privately for a short-term stay because you don't qualify for rehab, but you really need more time to recuperate. For whatever reason, the other options don't make sense. You would be going in for a short-term stay that could become a long-term stay. And that's, again, where that financial information is asked. Reimbursement, I've kind of touched on indirectly, but reimbursement for a nursing home is Medicare and your private insurance when you are in the subacute rehab phase. It would be private pay or Medicaid, or if you have long-term care insurance that covers nursing home. Every long-term care insurance you kind of tailor your own policy. So it may be that you have a long-term care policy that does not cover nursing home. But typically, I am seeing that as one of the things that's covered. But in any event, long-term care may very well cover your stay. So, how do you choose a nursing home? If you are in the hospital and you're looking for subacute rehab, boom, it is, you don't really have much time. You've gotten the discharge, the PT is saying, yes, you can benefit from rehab. The doctor's writing the discharge order, the family, it doesn't have time to go out and take tours and what have you. So if you can do that kind of work when you have the time and familiarize yourself with some of the nursing homes that, you've heard, that maybe a friend or a neighbor or family has gone and said this is a good one or that isn't a good one. It's not a bad idea to take some tours to prepare yourself for that eventuality. If you are going in, and kind of similarly, if you're going from the hospital at all, you don't have much time for tours. I can tell you that the families I work with are doing their very best, and they're running around and seeing places. But it's certainly better to familiarize yourself before the deadline is there. And very often, I am seeing folks who have been home. Family is caring for them. They have the assistance of home care that has worked well for a period of time. Then, as their loved one declines, they get more home care. The caregiver is getting more stressed, and at a certain point in time, it looks inevitable that nursing home is needed, and families will wait because they're fearful, and they shouldn't be, but they will wait because they want to provide the care they love. They love their family member. But in preparation, when you are caring for someone at home, and you're seeing the inevitable down the road, which typically, someone has a disability, maybe, physical, Parkinson's or stroke, or dementia, where the trajectory is such that there will come a time. Take a tour. And when you take a tour, as Caitlin mentioned, it's really very much the same, except that there's even more services to ask about in a nursing home. But you really want to use all your senses. You want to go in and, note the smell. You have a question?
I might be confused, which wouldn't be normal for me, but
No problem.
it's my understanding, like, suppose you go out and visit several homes and you're like facility A.
Right.
When discharge comes, isn't it they send you where the next available bed is?
Well, what happens there is, we're talking about rehab in this instance, I'm assuming. Or even either one.
But coming from a hospital.
Coming from a hospital, in any event, when it's time to go, the district, well, before, because as Caitlin mentioned, as soon as you enter the hospital, they're getting ready for discharge because it's going to happen, and it's going to happen quickly, and it's going to happen much more quickly than you're prepared for. So they will give you a list of nursing homes, and they'll say, give us 5, give us 8, whatever, your choices. Okay, and the discharge planner then will send the information to the nursing home, but if there are no beds, if there's no beds in your top 8, then they're expanding the search. So it's good to have it's good to know what you want in advance. But and if it's rehab and you pick 8 nursing homes that you like, you're likely to get a rehab bed. You're likely to. If it is a long-term bed, then they're looking at the rest of the picture. What your financials look like, and what you look like in terms of what kind of a resident you may be. What are the complications. That's a whole other ball of wax. But when you take your tour, ask questions and look. I mean, you're going to ask all the questions, but it's very important, as I said, to use your senses. So you're looking around. Is it clean? Are residents dressed? Are they out and about, versus in their room? I mean, some residents may need to be in their room, and if you go to a nursing home between 2 and 4 in the afternoon, that's nap time. But look at the interaction. Observe the interaction of the staff with the resident. Are they saying, "Hi, Betty, what can I do for you?" If Betty's smiling. You want these staff to be involved with the residents. You don't want to see them, chatting at the desk and there's somebody over here, trying to get your attention. These seem like, these really are obvious things, but pay attention to all of that, in addition to asking about activities and religious services and all the rest of it. Once you are in a nursing home, once your loved one is in a nursing home, be it short-term or long-term, your role as an advocate continues to be very, very important. So in my experience, I see families choosing a nursing home that's close so that they can visit, and that's a very important criteria. So you want to be involved. Obviously, your loved one wants to see you, but beyond that, it's great for staff to see you and to ask any questions that you have concerns about. You can always ask for a family meeting if the concern is more complex and you want to have a multidisciplinary meeting, you can request that. But stay involved and don't hesitate to ask for help. Don't hesitate to say, Mom's nails need a clipping, which is something that's an age responsibility. Whatever it is, don't hesitate to be the best advocate that you can be. I think we can stop with that, and
I can just put one more little piece out there. When it comes to assisted living, probably you hear on the radio, you see it on TV, that there are agencies, that this is free to you, it's not going to cost you anything, and we're going to help place your loved one in an assisted living community. They're not doing this out of the kindness of their heart. It may be free to you, but they are making a few $1,000s every time they move someone into a community. So they sign contracts with different communities that are out there, and I can guarantee most, not all, are going to try to persuade and get you to go to a community that they have signed a contract with, so they'll get the money.
yeah.
So just be aware of that. If they're saying it's free, they are getting paid somehow. And I mean, there are some out there that are good. There are some out there that I'm not particularly fond of, but ask those questions. Who do you have contracts? and ask who the last 15 the last few communities that they refer to. Because if they don't have a contract with you, they're probably not going to try to refer to you. And there could be a great community out there that would be a perfect fit for you, and they're not going to make you aware of that. So just another quick little piece. Okay.